Okay, let's go.
Yes, sir.
This is Dr. Alan Jobe from Cincinnati, Ohio, and I'm presenting a talk on what neonatologists should know about antenatal steroids and postnatal steroids for the International Neonatal Summit from Kerala, India. And thank you for the opportunity for me to address you this morning. It's morning here, it's probably evening there. The slide isn't advancing. I can't advance the slide. Oh, there. I can do it over here probably.
Yes,
Okay,
sir. Yes, sir, it's moving.
So I just continue?
Yes, sir, please go ahead.
My project funding is from a variety of sources. We've been doing animal models in sheep and monkey models at UC Davis with support of the Bill and Melinda Gates Foundation. We also did a clinical PK/PD study with Syngene in Bangalore, India, and I'll talk a little bit about that. GSK has provided the steroids for the infusion studies in Australia, and Merck provided the betamethasone acetate for us. The goals of this presentation are to appreciate that preterms have IQ deficits and acknowledge that we do not understand the causes of that. There are differences in the drugs and effects on newborns, of course. And I want to talk a little bit about the developmental origins of health and disease concept, which may be unavoidable because of bad effects that we cannot fix with our current therapies. I have 6 suggestions about dosing antenatal steroids and postnatal steroids. Okay, these are just sketches that I did myself just for concept. There's 2 curves here. There's the normal IQ distribution for normal term babies. And then there's my sketch of what it looks like for very preterm. The preterms have 3 red circles on them. One is that the peak value is actually downscale from the normal potential. That's about 10 or 15 IQ points. We know that's true in populations. The one on the shoulder there suggests that the shoulder is wider for kids in the lower IQ range. And then there's a bump at the bottom. That's for the very damaged babies. Fortunately, there's not too many of those any longer. These are studies, these are meta-regression analysis, standardized to mean difference in IQ for extremely low birth weight or very low birth weight infants versus term controls. And you can see the dark curve intercepts at about half a standard deviation below normal. Each of those circles, blue circles, represents a study, and the size of the circle represents the number of patients in the circle. So what this basically says that there's been no improvement in IQ between 1990 and 2010. So our little babies are still not doing optimally. Could this be the result of antenatal steroids? I think so, we just don't have any information. This is the same information with the outcome being BPD. And you can see if you get BPD, you have a significant deficit in your IQ based on percent bronchopulmonary dysplasia in the population you're studying. So these are studies from Finland a number of years ago on birth weight and head circumference. So these are all antenatal steroid exposed fetuses that are either preterm, born near term, or born at term. The term ones are the interesting ones because these are babies that were exposed to antenatal steroids but did not deliver until term because they actually never had preterm labor in all probability. And what you see is there's a deficit in their birth weight and there's a deficit in their head circumference. So this is the biological substrate on which our poor developmental outcomes are occurring, and antenatal steroids impact birth weight and head circumference. This is a population of 800,000 deliveries. This is a different publication of all the births from Finland from 2006 to 2017, 670,000. So the entire cohort of deliveries actually favors no antenatal steroids. And the term deliveries exposed to antenatal steroids have more of a deficit. The preterms exposed to antenatal steroids that delivered preterm actually don't have a mental or behavioral deficit in these Finnish children, probably because the steroids actually improve outcomes for the preterms, but not if you're given steroids and then deliver a term. So I think that's an important concept to remember. This is talking about the lung now. This is a slide I drew up a few years ago, where we thought that severe BPD was actually a deficit in alveolarization. It's probably a delay in alveolarization, but at term or as young children, these kids appear to have normal alveolar numbers based on MRI studies. So the question really is how do they age? Those are those dashed lines there after they reach their normal. The preterm, the severe BPD probably may age more rapidly than the normals do, but even the normal preterm infants age more rapidly as age progresses than normal term infants in terms of their airways and their alveolar number. So these are outcome studies. You've all seen these of the meta-analysis of Roberts for antenatal steroids, and they're pretty compelling. They decrease death, they decrease RDS, they decrease NEC, IVH, and late onset sepsis. So there's compelling reasons why we should use antenatal steroids, but what I'm going to tell you is I think we've been using the wrong drug at the wrong dose. This is the same kind of information conceptually. This basically is the rate of fall off of FEV1 as a child ages between birth and there's actually data now at 36 years of age. And so if you're a child that's born with one of those upper curves, you have normal airway function as you're aging. But if that's the red curve. But if you're a preterm, you end up with a low FEV1 in middle age, which means you're very likely to develop COPD. This is also an important concept slide. This is from Barbara Schmidt, looking at outcomes from her caffeine trial in terms of probability of a poor neurodevelopmental outcome at 18 months with added morbidities for these preterm infants. So if you have BPD, as I already showed you, you have a worse outcome. If you have brain injury, which is IVH or ROP, you have progressively poor outcomes up to about 90%. So this makes a very important point that if we're going to improve outcomes, we have to try to decrease the injuries that these babies receive. And those really are BPD, NEC, brain injury, and ROP. So the summary of these outcomes in our preterm infants are that antenatal steroids may cause early aging. We have some other, I don't have time to present the data for the preterm for the heart and lungs that may be caused by antenatal steroids. The DOHAD concepts about metabolic syndrome may be a substantial risk for the preterm. All preterms seem to have an increased risk of having metabolic syndrome in early life, which does, of course, predict heart disease, cancer, and other bad outcomes. We unfortunately have no clue about how to avoid other than preventing prematurity. And without a thorough understanding of the developmental pathways, we're not going to be able to develop therapies to minimize this. What we should do, though, is minimize antenatal steroid exposure to ideally only pregnancies that will benefit. Those are the ones that will actually deliver preterm. How to make better babies, avoid the injury, learn there is no obvious to avoid the DOHAD effects if at all possible. We don't know how to do that. avoid prematurity by giving antenatal steroids only to pregnancies that will benefit. And I'll talk about lowering the dose. So when we think about steroids, I think we have to think about a differential equation. So these are respiratory outcomes. These could be GI outcomes, it could be brain outcomes, it could be anything. We have fetal exposure, we have very preterm exposure. People are using a lot of steroids for blood pressure support. And then we have postnatal injury, and we use them early in the course of BPD. I'll talk a little bit about that later. And we also use them chronically for babies who have severe injury, who are in a stage of lung repair and remodeling. So it turns out that some use of steroids is actually very high, and we have to be aware of that. We usually don't think about previous exposures. So for antenatal steroids, the drugs used are betamethasone. I think that's what's used predominantly in India, 12 milligrams. Twice. And so that's for 20, the total dose is 24 milligrams. Postnatal, we use dexamethasone or hydrocortisone. I'll talk a little bit about that. The WHO trial used dexamethasone or dexamethasone, 4 doses of 6 milligrams or 2 doses of 12 milligrams. Betamethasone phosphate, it can be given as 2 12 milligram doses. That's what's used in the UK. The interesting thing is all of these doses are 24 milligrams. And the recommendation for the patient dying of COVID who's in an ICU to use dexamethasone is a 24 milligram dose, is a 20 milligram dose. So actually, the dose we're giving to women for risk of preterm labor is higher than the dose we give to patients dying of COVID, which probably doesn't make any sense. So what are the characteristics of adrenal function in a preterm infant? They have very low cortisol levels as a fetus. So the cortisol synthesis is only significant after about 30 weeks of age. Preterms are generally adrenal deficient at birth. And I'll show you some data that they do better when treated with low-dose hydrocortisone because they're relatively adrenal insufficient. The pharmacology is really complicated here because we're treating the mother to treat the fetus. So the variables are the dose and route, placental transfer, clearance in the pregnant woman, clearance in the fetus, which is very slow for betamethasone. The other issue is what is the dose for the effective pharmacodynamic outcome that we want? For example, preventing IVH or RDS or death. We actually don't know what that is for each of those outcomes. So this is, I think, interesting information to think about. This is a recent trial from France, which is not yet published and complete, on cord blood levels or maternal levels. The maternal levels are on the upper frame and the cord blood levels are on the lower frame. And the circled areas are at 3 to 4 days after the second treatment. And what you can see is that the fetus and the mother still have significant levels of, this is for using betamethasone as betamethasone acetate plus phosphate, as we use celestone in Europe and in the United States. So the point of this is that because of the acetate slow release form of the betamethasone, the mother still has betamethasone in her circulation 3 to 4 days after the last treatment. And we've measured it in the women in India, and we can still detect it after 10 days. So, and the fetus still has a relatively high level, which is above a therapeutic range after 3 to 4 days. So this is the work we did in Bangalore. We gave groups of 12 women dexamethasone, that's in the orange, betamethasone phosphate, or the clinical drug we use in the US and in Europe. And that's this mixture of beta-methazone phosphate plus acetate. And what you see is the initial curve is a relatively rapid clearance. It's more rapid for dexamethasone than for beta-methazone. And the triangles are actually for the celestone drug. What you can see is after 240 hours, to as much as 288 hours, that's 10 days, 11 days, we could still measure it in the maternal circulation. So this is what happens when you give maternal cortisol or any one of these combinations of beta-methazone phosphated acetate or beta-methazone phosphate or dexamethasone phosphate. The initial part of the curve there at the minus 24 hours is the normal circadian rhythm in these normal non-pregnant women in Bangalore. And then the next morning, when their cortisols are up, if we give them only a 6 milligram dose, what we do is we profoundly suppress their adrenal. And when we use the celestone treatment, it's completely suppressed for almost 70 hours, and it's still suppressed at 96 hours. So the take-home message from this is, with the standard dosing that we're using for maternal therapy, when your woman is on the labor ward, she's actually adrenal suppressed, which may not be a good idea given the stress of preterm labor on these women. This is reasonably new data from a very large study from France, looking at cortisol concentrations in male and female infants. And it turns out that it looks like a shotgun blast. So there's a bunch of babies that have very low cortisol levels. Those are the babies that are the normal preemies who have adrenal insufficiency because they haven't gotten around to make much cortisol. And there's some that are extremely high. Those are mostly babies that had chorioamnionitis. And it turned out when they correlated cortisol with outcomes, the babies with these high values had more BPD, more NEC, and more death. So that if you have a baby that's a very preterm infant that has a high cortisol, it's probably not a good idea to give him more corticosteroids at that point when his steroids are so high. So I would suggest that when you get your initial blood values on a baby, that you also get a cortisol to try to learn if this is one of these babies with a really high cortisol level, in which case you probably don't want to be using cortisol in the first few days of life. So this is a summary slide. This dose of 0.125 milligrams per kilogram of beta acetate is half of the dose that these women get with the conventional dosing. So it's a low dose. The maternal and fetal blood levels for lung response are very low. They're less than 1 nanogram per milliliter, probably even lower in pregnancies. A dose of 0.06 milligrams of beta phosphate showed less lung response in the macaque monkey. Therefore, lung maturation does not require a high peak level of steroid, beta levels in the fetus or dexamethasone. The fetal levels are low and need to be maintained for 24 hours with beta acetate. These are actual blood levels in monkeys who had effective lung maturation. The black squares are beta acetate in non-pregnant monkeys. The aquamarine blue is maternal levels, and the green levels are in the beta with beta acetate in the fetus, doing by cortocentesis in these fetal monkeys by the skilled people at UC Davis. And so you see we got lung maturation with a exposure dose in the fetus of about 1 nanogram per milliliter, which is way below what the mother is seeing when we give these drugs. So, and this is just showing the kind of response you get. We get a pressure volume curve response and a surfactant response in the BAL of these preterm monkeys with 0.125 milligrams per kilogram of this is celestone. So beta acetate. Let me just say there's no drug available. It's just beta acetate on the market. You can get beta phosphate, dex phosphate, or celestone. You don't have an option to use beta acetate. So you get a surfactant response, and you also get a pressure volume response with the low dose of the beta acetate, which I just showed you caused a blood level of 1 nanogram per milliliter in the fetal monkeys. These are plasma levels in sheep treated with, again, this low dose of beta acetate. The maternal levels are about 3 nanograms per milliliter, and the fetal levels are about 1 nanogram per milliliter, and these animals responded with lung maturation. So beta phosphate and dex phosphate are equivalent except for the PK. The PK is fast, clearance is faster with dex than with beta phosphate. So actually dex is a good use. It's easier to control dosing. It turns out that blood levels in monkeys and in sheep are entirely proportionate to dose. The minimum of dose, and assuming anti-inflammatory effects, have some exposure requirements. For the lung, this is, for BPD, we think this is about 2 nanograms per milliliter in the newborn. That's about 0.06 milligrams per kilogram of dexamethasone. So this is another thing about lung maturation that's really interesting, something we found a number of years ago. And that's when you cause inflammation with chorioamnionitis, you actually augment fetal lung maturation in rhesus monkeys by giving them the combination of beta acetate, again, the low dose that causes a very low blood level, and intraamniotic LPS, as you can see with both the PV curve and the saturated PC and the BAL. This low dose works in the face of infection. So how can antenatal steroids be improved? Well, one of the things that nobody talks about when you go consent a mother to give her steroids is that actually only about 40% of the fetuses respond. Lung inflammation causes a more consistent lung maturation in animal models than does antenatal steroids. It's better to target antenatal steroids who will benefit, and consider repeated doses as possible adverse effect for possible adverse effects. And lower doses are important. It turns out we don't have lower dose data in the human, so I can't actually make a recommendation for what your lower dose should be. But there is a trial being started in India and Africa and Pakistan by the WHO and the Gates Foundation using a lower dose strategy. That'll take a couple of years to complete. So this is a recent trial that was published last year from the WHO called the ACTION trial. It was 3,070 fetuses were randomized to 4 doses of 6 milligrams of dexamethasone. And I think this is what you're using predominantly in India. It was an RCT with a controlled trial of antenatal steroids, the first since 1993. For infants with known gestational age and risk of imminent death, the birth outcomes were not different. Only in facilities that could provide complete some delivery and postnatal care for the mother and substantial care for the infant, these are truly not low resource facilities. The trial was stopped after the second DSMC review of the data because there was a decrease in infant death, which was significant. And so this trial used 4 doses of dex. So I think in India, presently, that's the right way to treat women. So why do only 40% of fetuses respond? Well, it could be that the drug exposure to each fetus because of differences in maternal blood level placental transfer or fetal levels and clearance. There's different drug exposure. There could be biological difference. So what we did is we did a sheep study where we gave mothers either saline or the clinical drug celestone and measured maternal and fetal blood levels. And then we looked at responses, and the responses were for PaCO2. You can see that the preterm delivered animals that were then ventilated, who got, we defined as responders, did pretty well. It turns out that the maternal and fetal total betamethasone levels were identical if you're a responder or a non-responder. So this means that giving more drug isn't going to help because you don't increase the percent responders. What you need to do is use the 6 milligrams of dexamethasone and just recognize that not all fetuses respond. So presumably this is at a receptor level or a biological level in the lung, and that's something we're trying to study. Many women exposed to antenatal steroids do not benefit. The fetus is already mature, even at an early gestational ages. Most fetuses at greater than 34 weeks gestation don't benefit because they have a very low risk of RDS or death. So are there opportunities to identify and treat only pregnancies with benefits? We don't know how to do that very effectively. So there's a bunch of residual questions with antenatal steroids. We do not know the actual low dose that the fetus needs to respond to. In the sheep and the macaque, it's 1 nanogram per milliliter. So because of biological convergence, it is unlikely to be an artifact. So the value should be about 1 nanogram per milliliter. And we can figure out what the fetus is exposed to by measuring these things in cord blood. So the take-home message is that most preterms have dex or beta in their plasma at delivery, perhaps not beta because it's cleared faster. I do not think we understand the adrenal function in these extremely low birth weight infants. I showed you that data that some of these kids have extremely high steroid cortisol levels endogenously. The present steroid dosing is very high, but I cannot recommend a better dose because we don't have any clinical data. And there's an increased risk of hypoglycemia with this dosing. So I'm going to talk about postnatal steroids here for the rest of the talk. My problem here is I'm giving really 2 talks, one on postnatal and one on antenatal. So when we think about steroids, there's a pharmacologic effect at the high dose range. There's a stress effect that we all need if we're going for surgery. And then there's a lion's chasing you. I guess in India, that would be a tiger. There's a basal level that we all have to have or we can't maintain our blood pressure. And the toxicity is proportionate to dose and duration of therapy. So there's major pathways in BPD which may be sensitive to steroids. One is lung development, the other is the issue of injury, and the other is the issue of repair. We don't know how that's, when we give steroids, we're probably affecting these 3 different pathways, complex pathways simultaneously. These are a summary of a bunch of recent reports on either inhaled steroids, 10 days of hydrocortisone, or targeted steroid use by putting the steroid in the surfactant. And it turns out that there was decreased death with a 10-day hydrocortisone or with the budesonide plus surfactant. It seems to me that all of these things have a decrease in BPD and some have a decrease in death. Therefore, the results are convincing proof of principle that early steroid uses are probably useful in our preterm infants. The problem is which drug, which dose, and which route. So the NIH recently completed a trial that was just reported in the New England Journal of Medicine. It was a multi-center trial of 800 infants less than 30 weeks of age. The treatment was 4 milligrams per kilogram of hydrocortisone for intubated infants who were at 14 to 28 days of age. The dose of hydrocortisone was tapered over 10 days. There was no difference in hydrocortisone cortisone versus saline for death, or BPD, which were the primary endpoints. The high hydrocortisone did permit earlier extubation, but it caused more hypertension in the preterm infants. There was no effect on neurodevelopment or growth at 2 years of age. So it's reasonably safe to use as long as you're looking out for the hypertension. I want to talk about this trial because most of us, this is how we dose postnatal dexamethasone for that. The previous one was hydrocortisone. This is for dexamethasone. This is the DART trial, which was published in 2006. It's quite interesting because it was designed for like 3,000 babies, and they could only enroll 192. 70 were randomized, 35 to dex and 35 to placebo. These are infants that are less than a kilogram, less than 28 weeks, on a ventilator at 7 days of age. The power calculation for this study was 800 babies. It turned out that they only could treat 70 because there was this concern about using dexamethasone, so people couldn't get consent. This is, I think, conceptually a really important slide from Lex Doyle. It's again a meta-regression. The size of the circle is the size of the study, and it's looking at effect on death or cerebral palsy based on the rate of BPD in your control group. So this is the other little babies in your NICU. So it turns out that if you have a BPD rate of about 50%, if you use steroids, you'll have better outcomes in terms of death and CP. If you have a really low incidence of BPD, then it's probably more likely to be toxic. If you have a high incidence, a high incidence of BPD, then it's more likely to be toxic. So there's this new approach, which is being studied in 2 large studies, one in Australia and one in the US by the NICHD Neonatal Network, on corticosteroids to prevent BPD. This is mixing budesonide with surfactant when you treat these preterm infants. And we've done some lamb studies. Lambs delivered and ventilated at high tidal volume for 15 minutes to injure the lung. Lambs were randomized to 200 milligrams of Thrissur or surfactant plus mixed with the Thrissur, and they were ventilated for 6 hours. And it turns out that the ones that got the budesonide were on lower mean airway pressure, they had a better ventilation efficiency index, and they had much lower cytokine levels. So this therapy is now again being trialed. But just as a cautionary note, this is work that we've published now. It's in, I can't remember where it's published, but these are heat diagrams of RNA from the liver of preterm lambs. And it turns out that when you use any steroid, you get a large number of genes that are expressed because of the steroid in the liver, in the brain, and in the gut. And this is just to follow up on my concept that I started out with. If you're a child and you're alveolizing up until the age of about 20, from that point on, you lose alveoli and you lose the integrity of your small airways, such that if you get below a certain range, you have COPD. And we probably have increased aging with our preterm infants, and certainly with our tiny infants that have lung injury. What is optimal antenatal and postnatal steroid treatments for efficacy and decreased potential for injury? Low total fetal exposures achieve benefits, and we don't need high peak levels, and we need a minimum duration of exposure to get a benefit, probably about 48 hours. And we're looking for a maximum durability of response so that if we treat the woman, we'll have an effect at 7 days when the baby's delivered. We want a rapid onset. We want a high availability and low cost for low income and middle income countries. We want to minimize potential risk for postnatal steroids we can probably lower dose. This is an even newer study about a network meta-analysis of 62 studies on 5,500 infants. The primary outcome was mortality. Primary outcome was BPD and mortality at 36 weeks. They found in this meta-regression analysis that the best dosing was a moderately early dose. That's between 7 and 14 days, 8 and 14 days, pardon me, with 6 systemic dexamethasone, the total dose of 2 to 4 milligrams per kilogram. Not grams, I'm sorry about that. Don't give grams. For 8 days. And they said that it was a low quality of evidence as this being the best way to dose our post babies. So again, to dose, the best information we have now for giving postnatal steroids to treat BPD is to give it between 8 and 14 days for babies who are on a ventilator, give it for 8 days and use a low dose of 2 to 4 milligrams per kilogram. But it is a low quality of evidence. Thank you very much.
Thank you so much, sir.
Was that okay? How long did I go?
40 minutes perfectly, sir.
Good.
Perfect time. It was so revealing. I was just amazed hearing your talks. I mean, like, this is totally new information. Most of the things are totally, against the prevailing concept. So, like, it's really eye-opener, the talks.
Yeah, well, the problem is with the antenatal steroids, we don't have clinical data to tell people what to use as a lower dose. So
Okay.
I think the bottom line is you're using dexamethasone in India?
Yes, we are both. People are using both actually, but the betamethasone only the phosphate, not the complex salt. So
Yeah,
most of the people are now changed to dexamethasone because of this reason.
yeah. Well, you don't have the complex one in India.
We don't have. We don't have.
We had to smuggle that into the country to get that to
That,
use it with women.
that is
So
what I
anyway,
wanted to ask you. How the trial? How could that be done?
we actually did get permission to use it, but
Okay.
it took a long time because it's a new drug in your country, and India doesn't like new drugs.
Probably you are right, sir, regarding that.
So at any rate, well, thank you very much, and I'm
Thank you
happy
so
to
much.
Alan Jobe is not available for asking questions.
Thank you so much.
Is available? I think you'll have to stop it. Okay, so into the lessons, what we learned. It's a very important area because we are constantly, as neonatologists, constantly dealing with preterm babies and management. So the lesson mainly learned from this one is from antenatal corticosteroids are magic bullets, definitely for preterm babies and preterm mothers from 24 to 34 weeks of gestation who are in imminent danger of preterm delivery. Actually, in many places, it's overused. I am saying this for even for my daughter, she's from North Kerala. When she reached 32 weeks of gestation, they started giving steroid. Surprise asked them and stopped it. They say in case she goes into labor. So that practice may be there in many hospitals also. A surprise, even in Madras, I think, maybe. Don't know. So ideally, we should limit it to mothers in preterm labor between 24 to 34 weeks. The study about the late preterms and also elective cesarean sessions also again confusing. Some of the studies have come out showing that it's definitely beneficial in the way that it reduce the incidence of mild in TTN or some respiratory distress or the baby requiring oxygenation or mechanical respiratory support. But if you don't give steroids also, they may not require much treatment. It's probably keeping the TTN baby for one day in the hospital like that. So that is septic. We require more studies to come before we say that we give for late preterms as well as for elective cesarean at term. So that is one important point he also said. And another important point he has brought out in the discussion is, are we giving very high dose of steroids? Nobody has looked into, because so many landmark studies, especially that study that is published in Cochrane. Even the Cochrane, that marking is based on that flow chart and what is that statistical analysis they put it there on top. So that study definitely showed it reduced respiratory distress syndrome to the tune of about 34%, reduced IVH, and also NEC, and also late onset sepsis. So that is the only study. So nobody had done so much studies on the dose. Alan Jobe saying that we have a lesser dose may be enough for this. So somebody should do studies on that also. And regarding postnatal steroids, he said same. We all follow that DART trial principle only. Moderately early dosing, that means from 8 to 14 days, dexamethasone, 2 to 4 milligram per kg. That is been shown as the best dosing. And that too only in situations we are stuck with the baby, we are not able to extubate the baby. In such situations, go for early, moderately early steroid. Otherwise, a very early steroid as well as late steroids both can have problems. Then another study here, he showed that what is done by Raikkonen et al. In JAMA, this 2020, it has been published, that many mothers who get steroids, they don't deliver prematurely, but they go on to term. And these children followed up 10 or 12 years later, they seem to have behavioral or neurological problems or even mental retardation. So that's a bit worrying, but all said and done, we are concerned about the positive effect of antenatal steroids. And in Indian situations, different also. Even there is a study recently from India showed that only 57% of the mothers are getting steroids. So we are still at the other side. So definitely the good effects of antenatal steroids should be there, but at the same time, we should be careful about its overuse also. That is the main thing. He would have been there, but he is, I think, is laid up and is going for a major surgery or something. And otherwise, he would have been here. So anything on to Leela, Dr. Leela? Your experience, Uma? You will be dealing with a lot of cases, preterm baby.
It's very true that sometimes antenatal steroids are overused. So we are always on extremes. Either like we do not use. If we start using, like we overuse. So we have to balance all the aspects. I think that should be from our OBG colleague rather than from us. Postnatal steroids, we kind of use the calculator, NICHT calculator, to calculate the risk of BPD or BPD calculator. And if the risk is more than 60%, then we consider postnatal steroids. So we use the DART regime as such in our unit, but I would say that it is only very minimal usage of postnatal steroids.
I think we are running out of time, so probably we can stop this and go on to the. So thank you very much for